Outfitters, welcome to the CMEO snack entitled Global Perspectives in Atrial Fibrillation and Venous Thromboembolism, Reassessing the Role of DOAC Treatment in Special Populations. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. The activity is sponsored by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance. As mentioned, I'm Gregory Lipp. I'm Price Evans Chair of Cardiovascular Medicine and Director of the Liverpool Centre for Cardiovascular Science at the University of Liverpool in the United Kingdom, and I'm also affiliated with Aalborg University in Denmark. And I'm really very pleased to be joined today by my good friend and colleague, Dr. Jan Steffel, Vice Chairman and Professor of Cardiology and Senior Cardiologist for Invasive Electrophysiology and Cardiac Devices at the University Hospital in Zurich, Switzerland. Welcome, Jan.
Thanks a lot, Greg. Great to be here. I look forward to our discussion.
Excellent. We'll be starting today by discussing DOACs in atrial fibrillation. And this will be followed by part 2, which will focus specifically on venous thromboembolism. Here, our learning objectives are in relation to using DOACs appropriately. So let's make a start. So Jan, perhaps a good place to start is the 2021 European Heart Rhythm Association Practical Guide. Perhaps you could walk us through some of the main highlights of this update.
Yeah, I'd love to, Greg. Thanks a lot again for the intro and for having me today. I think this by now 4th edition of the ERA Practical Guide came into being really because we felt that after the 3rd edition, there were again more and more data accumulating and more experience accumulating. Also, that would help clinicians or healthcare providers in general to best treat patients with NOACs. Now, you, of course, very few people that would know that better than you because you were fortunately our coordinator for the reviews, which was obviously a very responsible job because we ended up with hundreds of very constructive and great reviews, which ultimately made this not only a multidisciplinary approach to this program or to this document, but also really an international approach. We had reviewers from all over the planet, from Southeast Asia, from Latin America, from everywhere. So really a great effort. And what we're doing in this ERA Practical Guide ever since its first inception in 2013 is we're trying to cover topics that are relevant for physicians or for healthcare providers in general clinical practice. And the guide is not too much focused on studies and on trials, right? Although we try to be sticking as closely as possible to the evidence, there are certain gaps in the evidence, even with such well-studied medications like NOACs. But nevertheless, we have the patients in front of us, so we have to deal with it. And looking at the table of contents of our guide, you will see that a lot of the topics, especially in the first couple of sections, are the ones that I guess today are maybe less relevant because we're kind of used to the seemingly trivial aspects, like how to start somebody on a NOAC, how to switch, what to do if somebody forgets a dose. We should not forget that a lot of healthcare providers across the globe are only now getting access to NOACs. And so this is why we decided to keep this in, because these are nonetheless very important topics for them, while they're maybe less important or less prevalent for us, but we would need to look things up. Now, in contrast, when we take a look at some of the other sections are probably more relevant because they're still dealing with conundra that are still not entirely solved. And maybe we can touch on a couple of those during our chat.
Absolutely. And I think the objective really of the guide is a practical guide. And the point is, we obviously have the large and well-conducted randomized trials. But randomized trials, of course, have very specific inclusion and exclusion criteria. And when the drugs are now available in clinical practice, they are for a much broader population. And you could say, the outpatients in everyday clinical practice, some patients are underrepresented in the randomized trials. And furthermore, they don't always obey textbooks, do they? Or nor do they obey guidelines. So I think this is a real important contribution to the practical management of atrial fibrillation. So maybe you can flag up some of these specific conditions, which perhaps, as we discuss, are a little bit underrepresented in the trials, and maybe many of us encounter in everyday clinical practice.
Yes, absolutely. And I think while you mentioned it, I mean, I don't think there are many drugs or substances, not in cardiovascular medicine, probably not anywhere, that are as well studied as NOACs, including, like you said, the RCTs and the observational data. What we do not have, at least not in form of a randomized trial, is a direct head-to-head comparison with any NOAC A against NOAC B. And that's, I think, a real big gap, because ultimately what we have to acknowledge that although NOACs are the preferred therapy, as we can tell from the trials and certainly as manifested in the guidelines, including the latest ESC guidelines from last year, they're clearly the preferred therapy. There are differences between the drugs, and on various levels. It starts with bioavailability and absorption. There are relevant differences, like, for example, that the dabigatrans only resorb about 5%, whereas rivaroxabans resorb 100% if you take it with a nice meal. It needs to be taken with food, otherwise resorption is much reduced. I'm saying that because I see that in daily clinical practice, almost on a weekly basis, that patients that I tell that have never heard this before. Renal excretion, of course, is also an important differentiator between the drugs, right? Dabigatran, which is a good drug, very efficacious NOAC, is 80% renally cleared. So we need to look out a little bit, especially in those with moderate renal impairment. It's not to say that we can't use it there, but we need to be a bit careful and check these patients back more frequently in order not for them to drop, or for us to see when they're dropping their renal function, certainly below 30. Whereas apixaban, really with only 27% renal clearance, is on the other side of the spectrum. And we have some very good data for that, especially for apixaban, especially with respect to bleeding and safety. So there are important differences here from an absorption point of view, from a renal excretion point of view, also for that matter, from a hepatic metabolism point of view, because there again, there are some differences. Dabigatran, for example, is not at all metabolized by cytochrome P450. Edoxaban is only minimally metabolized by CYP3A4, whereas there's some metabolism for cytochromes P450 isoenzymes for both apixaban and rivaroxaban. Now, all of this, I think, is, again, we don't have any head-to-head trials comparing one against the other, but when we think about which NOAC is best for which patient, I think these are all relevant aspects that we can take into consideration and then trying to individualize care for these patients.
Yes, I think that's really important. And in fact, you flagged up the point that, one NOAC needs a nice meal. And I was actually going to ask you how to define a nice meal.
That's a very good question, of course. Ultimately, I think we have to acknowledge that rivaroxaban needs to be in the stomach for a while in order to be nicely prepared to be resorbed. And the way that it was originally thought was that you need a good breakfast, but we're really talking about an American style breakfast here. If you just take a yogurt and a small toast, maybe that's usually not enough. And I'm saying this a little bit in a joking way, but it is important, because if it doesn't stick around long enough in the stomach, it is not prepared enough for resorption. And as a result of that, levels might really be substantially too low and protection might be not enough. So if they do not take a good breakfast in the morning, they need to either take their rivaroxaban at another time point during the day, or they need to be in another NOAC.
Well, I think that's a really practical point, and so there are a lot of take-home messages from that discussion there. But let's turn now to another practical scenario, of course, and this, of course, relates to the perioperative management for the NOACs. And a question often asked is, how long should they stop a NOAC for a particular procedure, and then afterwards, when can we restart the NOAC? Because after all, we are dealing with drugs with a relatively short half-life as opposed to the vitamin K antagonists like warfarin, which hangs around quite a lot, and then and there's a slow onset and a slow offset. Perhaps you could sum up for us what the ERA Practical Guide recommends for us with regard to the perioperative management?
Yes, very relevant topic because it happens, like you said, it's so common that we're approached with that. And it's also interesting because when the first and the second version of the guide were published in 2013 and 15, we didn't have all the data really for this scenario, while now we do have some trials that have addressed exactly this topic. And it turns out, fortunately for us, that what we had been recommending in the past actually seems to be holding true when we take a look at it now through the eyes of trials like the PAUSE trial, for example, that have looked at this. What the bottom line is, obviously, we could talk about just this topic for a half an hour, but the bottom line really is that we can, for the majority of interventions, we can either perform them on minimally interrupted nights or with a short duration of interruption, so mostly 24 hours. Larger operations would require 48 hours of pausing the NOAC prior to the intervention. And there are some exemptions where it may be even longer, for example, cardiac surgery, neurosurgery, and some situations also with the bigatran if patients have reduced renal function, because in that situation, it'll take a little longer for the drug to clear. Now, the important take home from here is take a look at the tables and the figures that we've put in the guide, because I think it's a very useful way of also telling patients, look, this is when you have your operation, this is when you need to stop the drug. There's a second important take home, and that is don't bridge with heparin. Don't bridge with low molecular weight or unfractionated or whatever type of heparin you can think of. There are some studies, there's some data indicating that we're not doing any good for our patients in terms of bleeding, also not in terms of stroke. If anything, it will bleed more. There's also no necessity really from a pharmacodynamic or pharmacokinetic point of view, because actually NOACs and low molecular weight heparins act on a very similar target, 10A or 2A, and also their pharmacokinetics are very similar. So it's out of habit that this still happens, but if anything, we actually have data that we expose our patients to a higher bleeding risk. And then thirdly, and as you mentioned, I think it's also important to not forget to restart afterwards, because it's no use if you stop at the right time point and then for 1 week you leave them without protection. That's of course not the idea. In the majority of patients, it's okay to restart either in the evening of the operation, if it's really a small intervention, or the next day. Latest, usually after like big abdominal, thoracic surgery, cardiac surgery, neurosurgery, within 1 to 2 to 3 days afterwards. Now, this is one of the few situations where prophylactic low molecular weight heparin may play a role, just as a thromboprophylaxis for DVT, but not in the sense of a bridging therapy for full dose NOAC.
Oh, absolutely. Well, let's press you a little bit, because in a sense that many of my electrophysiology colleagues, and I'm pretty sure you do the same, is very much a move towards doing a catheter ablation on uninterrupted anticoagulation. Yeah. And of course, in the VKA days, there was a degree of comfort because in a sense that if something untoward should happen on a VKA, there's certainly a perception amongst cardiologists or electrophysiologists, they could handle an a VKA-related bleed. We, of course, now have the NOACs, and if it's an uninterrupted NOACs and a serious bleeding event occurs, then yes, there are reversible agents, but some have, there's different degree of availability. So maybe a practical comment from your perspective, because I certainly know of some centers very much changing to, say, the bigatran, because the reversible agents available on the shelf. There are other centers that, okay, with a factor 10A inhibitor, they still continue, but they certainly know how to handle. And some of those centers may have some access to andexanet alpha, which is the reversible agent for factor 10A inhibitors. Perhaps some thoughts on that.
Yeah, I mean, this is a very, very interesting topic, obviously, not only for me as an EP, but also in general, because obviously, if you're talking about catheter ablation for AF, you have a situation where on the one hand, of course, if you have a bleed, usually pericardial effusion or tamponade, it's potentially life-threatening, although it hardly ever is these days because we have become pretty good at handling this. Secondly, on the other hand, though, you're actively putting in lesions in the left atrium, which is of course thrombogenic, and as a result of that, you don't want to have too few anticoagulation, too little anticoagulation on board, because you would increase the risk of stroke. So it's a pretty special situation. And you're absolutely right. I mean, over the years, we've learned a lot. We were skeptical on how to do this in the past. What we used to do in the early days, we used to switch patients over back to VKA just for the ablation. Then we bridged them with heparin to the intervention, then with heparin afterwards, restarted VKA. It was a huge mess until we finally had some data that, first of all, also here, bridging makes no sense, neither when they're on VKA nor on NOACs. So do not bridge these patients. Very important take home for our viewers. Secondly, uninterrupted or minimally interrupted NOACs are safe in that situation. There's now good data, actually, with all four substances, that this can be done. Now, in once daily dose regimens, you usually switch them over prior to the ablation to evening intake. And then you just continue after the intervention 4 or 5 hours later with the regular dose. And it works very nicely. The trials have shown that. For the twice daily dose NOACs, there's a little bit of controversy whether you should give the morning dose or whether you should withhold the morning dose prior on the day of the ablation. In my center, I usually don't give the morning dose. There are some centers that do, and there's certainly data that this is also safe. I'm not completely convinced that it needs to be given. And that's exactly also for the reason that you mentioned, because you also don't want to have any bleeding complications. Now, fortunately, as I said, because these procedures are pretty efficacious and they're very safe these days, if they're done at a higher volume center, higher volume operators, we've become pretty good at also handling the complications. And therefore, today, pericardial tamponade, even if it happens under uninterrupted NOAC therapy, is an emergency. It needs to be taken care of directly, but it's usually not that life-threatening. When, of course, for the dabigatran, we have with iduricizumab what I would refer to probably as the best antidote that we have so far. It's pretty close to a perfect antidote, I would say. I mean, it's very specific. It works only on the dabigatran. It does not antagonize your heparin. If you needed that, you could give protamine, but you can give heparin afterwards. It's easily administered. And it really takes out the dabigatran out of the equation of a bleeding patient immediately. So this can indeed be quite handy in a situation like that. With that being said, we do have data also now for the 10A inhibitors that, as you mentioned, if you have an excellent alpha, it's pretty useful and you can give it. It's a bit more difficult to administer. It also inhibits other 10A inhibitors, including heparins, which doesn't make the peri-interventional therapy easier. And also, it's not available that much, like you mentioned, and it's actually pretty expensive too. So we do have some experience though that PCC, APCC actually also works quite well in 10A inhibitor treated patients. So I do not switch patients from a 10A inhibitor to dabigatran just because they have an intervention or an ablation. I think that's not really necessary. If they are on dabigatran, of course I keep them on it, but if they're on a good 10A inhibitor and I feel that this is the right NOAC for them, I keep them on it. And experience both from the trials as well as from the observational side really tell us that this is a safe way of doing it.
No, absolutely. Again, all very practical points here. We perhaps should move on to the wider atrial fibrillation population. And of course, we're dealing with atrial fibrillation, which is pretty heterogeneous. And on one end of the spectrum, you're dealing with a very young patient with structural, normal heart, where you could say is an electrical problem. So then if you go on to the other end of the spectrum, you could perhaps say is the more common clinical encounter, which is the elderly patient with atrial fibrillation with multiple comorbidities. And just to point out that from the randomized trials, there have been meta-analysis on the elderly cohort, and in the trials, most of the published meta-analysis have been in the age over 75, showing how the NOACs show certainly at least as good or sometimes better efficacy, and also, but certainly better safety in elderly patients with atrial fibrillation. We have published from large nationwide cohort studies looking at the extreme elderly, and we define those as age 90 and above. And again, clearly showing that when NOACs are looking compared to warfarin or vitamin K antagonists, They do prevent ischemic strokes, but they certainly do have better safety in terms of the major bleeding events when compared to warfarin. I suppose the other aspect really we should think about are the extremes of body weight. And maybe you can tell us what the ERA practical guide tells us with regard to low body weight and high body weight.
Yeah, I think that's clearly an important topic, but just briefly on the age topic, I think that's extremely important to have these data that you just mentioned, the observational data from the very elderly, because obviously these patients are at high risk for everything. For high risk for stroke, high risk for bleeding, and certainly high risk for undertreatment. So that's really a very important aspect that we now know that NOACs are also safe and efficacious, effective in these patients, because this way we can prevent stroke in them. Having a stroke in a very older or a very frail patient is usually a disaster. I mean, it's never a good thing in anybody, but it's usually an even bigger disaster because they hardly recuperate from it. And so to your point about the body weights, I think this is also something where we have a very nice scheme included in our guide, where you say that between 60 and 120 kilograms, just from a weight perspective, it's okay to go with NOACs at the standard dose. If you go below 60, you have a dose reduction as per labor for edoxaban and for apixaban. If for apixaban, there's another one of the two other dose reduction criteria. So we figured that probably in these patients, one of those two might be preferable. Now, in the very low and the very high body weights, on the other hand, we don't have that much outcome data from the trials for NOACs. We have to admit, we also don't have that much data for vitamin K antagonists with respect to hard clinical endpoints. So we need to make a bit of a judgment call. And again, we bring in this topic of plasma level assessments in these patients. This is obviously a pretty complex issue, and I guess that would be a topic in and of itself for a separate fireside chat. I would recommend our readers, our viewers to read this. We discussed this quite extensively in the guide. It's off-label. It's not evidence-based at this point in time, but I do feel that this is part of the future, what the future has in stock for us regarding NOAC therapy, because this will hopefully, my assumption is it will help us individualize and tailor therapy even better, especially in those vulnerable patient populations, streams of body weights, high age, old age, and multiple comorbidities. And of course, speaking of comorbidities, Greg, I mean, I think at the end of the day, you know, when we talk about AFib, atrial fibrillation management, of course, anticoagulation is one of the most important topics because stroke is the major driver of morbidity and mortality. But ultimately, an integrative care, as it is proposed by the ESC guidelines, is what defines modern AF care, right?
Oh, absolutely, because we put a lot of focus on stroke prevention and atrial fibrillation, and quite rightly so, because we certainly know how atrial fibrillation confers this high risk of mortality and morbidity from stroke, as well as dementia and systemic thromboembolism. But remember that stroke is one bit of atrial fibrillation care or atrial fibrillation management. And the 2020 European Society of Cardiology guidelines has moved towards a more holistic or integrated approach. And that's summed up as the atrial fibrillation better care pathway, or ABC pathway. And why is that? Well, the A is avoid stroke, or A is anticoagulation, where the default is stroke prevention unless the patient's low risk. The B is for patient-centered, symptom-directed decisions on rate or rhythm control. And finally, the C is the appropriate optimization of cardiovascular risk factors and comorbidities, as well as attention to lifestyle type changes. And that is evidence-based medicine. That is not eminence-based. It's not a VIP-based statement there, because integrated care management has been clearly associated with better outcomes. And this has been shown in a recent meta-analysis where in atrial fibrillation, in a population of atrial fibrillation patients, about 20% are adherent to the ABC pathway, but the adherence to the ABC pathway brings good benefits: a 58% reduction in death, a 63% reduction in cardiovascular death, a 45% reduction in ischemic stroke, and a 30% reduction in major bleeding. That's evidence-based medicine for you on hard clinical outcomes.
And that's excellent, because on the one hand, it's really intuitive and it intuitively makes sense. And it's great to see that it's also backed by hard data. That's precisely how we want it, right?
Absolutely. And, this is evidence-based, holistic and integrated management of patients with atrial fibrillation. And I think for the atrial fibrillation section, thank you very much for listening. And we will move on to part 2, which would be on venous thromboembolism. So Jan, our populations are aging. We are living longer with chronic diseases. And as a result, we're seeing more and more cases of venous thromboembolism.
Absolutely. And as a matter of fact, similar to AF, this is something that we're already seeing a lot today, and we will be seeing even more over the next years and decades to come, because people are getting older and older, which is a good thing. And as a result of that, they accumulate comorbidities. Those lead to atrial fibrillation, those lead to other things, and those lead also to VTE. And I think VTE is really something that's clearly underestimated. Also, as with respect to its morbidity, mortality that it brings. Actually, if you just take a look at it from a pure numbers perspective, it is one of the major drivers of morbidity and of mortality in Europe. Now, of course, usually a VTE doesn't come alone. There's usually something else that provokes it or that comes with it, other comorbidities, other factors. But VTE in and of itself is really a major driver of morbidity and mortality. Now, fortunately, we have agents to both treat this and to prevent this. And it's quite interesting how the guidelines have evolved over the last 20, 30 years with respect to what we had, what was studied for the treatment and for the prevention of VTE. And maybe before we dive into the NOAC data, Greg, you're gonna give people a little bit of an update or an overview over where we were and where we are today?
Yeah, yes, indeed. Because if we, in fact, you could say the same, whether it's for venous thromboembolism or atrial fibrillation. If you turn the clock back a decade ago, we're trying to choose an anticoagulant. Well, parenterally, we had essentially unfractionated heparin or a vitamin K antagonist such as warfarin. And now in 2021, yes, in terms of parenteral administered anticoagulation, we of course still have unfractionated heparin, but we have low molecular weight heparins. For the oral anticoagulants, yes, of course, the VKAs are still around, but in many situations, we have up to 4 DOACs available. So you could say we're a little bit spoiled for choice now. And then that applies to whether with atrial fibrillation or whether with venous thromboembolism. And it's probably fair to say that the guidelines have evolved accordingly. So for venous thromboembolism treatment in non-cancer patients, so if you think about the guidelines from maybe around 2000, it was essentially focused on unfractionated heparin and vitamin K antagonists. And in the latter bit of the 2008 or so, the guidelines started to evolve towards mentioning low molecular weight heparin or VKAs, and of course fondaparinul comes along the scene. And in more recent guidelines, in 2012 onwards, we're now getting recommendations, including the NOACs as an alternative to the standard treatments. And then now from 2019, we have NOACs, in fact, as the preference when you come to the more chronic sort of treatments in preference to the vitamin K antagonist. So the evolution clearly of the guidelines reflects the evidence base, both from randomized trials and also supportive evidence coming from large and well-conducted real-world studies. Now, in terms of the aspects about venous thromboembolism management, I suppose in terms of keeping practical to this fireside chat, in line with the earlier discussion on the practical atrial fibrillation management, one of the aspects obviously is with regard to the sort of longer term management of patients with venous thromboembolism, and this brings into the scenario discussion about particularly what to do in the sort of extended therapy for patients with unprovoked or venous thromboembolism, or I suppose you could contrast that with provoked venous thromboembolism. Maybe you could give us some insights on that, Jan, from how the guidelines are moving.
Absolutely, and I think this is something really exciting because there really the landscape has changed quite dramatically. On the one hand, NOACs now being the preferred therapy for the treatment as well as for the long-term prevention, like you mentioned, but also especially this long-term prevention aspect of VTE has always been suffering from the limitations of this provoked, unprovoked dichotomy that we've had, right? And this is from old data where we knew that especially those that were provoked by non-surgical factors or where you had no identifiable risk factor for venous thromboembolism, you would have a much different rate of recurrence afterwards. So indicating that this dichotomy is probably not entirely correct. There's actually not a black and white. There's 50 shades of gray, as in many areas in medicine, right? And so the 2019 guidelines for the treatment of pulmonary embolism have really moved away from this, and they have categorized this more on the risk factor severity, whether patients would qualify for long-term therapy, if they have a low and an immediate or a high risk for recurrence, and then really based on that, say if these patients need long-term therapy or not. If they do, then also in this situation, clearly we have good data now from the NOAC trials that NOACs, and sometimes indeed in even lower concentration or lower doses as during certainly the initial, but also then the actual treatment phase are required. And we have very good data that by using such very low doses, we can actually reduce the risk of recurrence quite dramatically and really at a very, very low cost in terms of bleeding.
It's almost like the conversation in the atrial fibrillation side between valvular AF and non-valvular AF, because of course that's the, and in fact the new guidelines even say that distinction is old-fashioned and obsolete, because we're really talking about, sorry to bring us back to that comparison, because it's atrial fibrillation with significant valvular heart disease, and that refers to prosthetic mechanical heart valves or severe mitral stenosis, and in the old terminology was so-called valvular AF. And then the other group is the non-valvular AF, in other words, AF without significant valvular heart disease, and AF without prosthetic mechanical heart valves or severe mitral stenosis. Anyway, I'll come back to venous thromboembolism again, because
but it's a very good comparison, I think, because ultimately it leads us to, but it also shows how really these not only these terminologies but also the science behind it changes. It's not that we kind of make up our minds and say this is stupid, but it's really data that have indicated that this black and white's probably not entirely correct.
Absolutely. So the venous thromboembolism guidance gives us this categorization into low risk and moderate risk and high risk. And I'll start off by giving my perceptions on this, and I'll be interested to hear your thoughts, because low, moderate, and high, that really is, you could say, artificial, because risk, after all, is a continuum of risk. And let's face it, we clinicians are not very good at identifying high-risk groups reliably with risk scores. And we certainly see this for atrial fibrillation. And hence the AF guidelines have moved towards offer stroke prevention unless they're low risk, or you could say, put it another way, the default is stroke prevention unless they are low risk. But the many guidelines still have this artificial categorization into low and moderate and high. How reliable do you think these are? I mean, is it good as a guidance? Now, in terms of the predictive value, I'm very happy to debate that.
Yeah, I think so too. And I think this is really a work in progress. I don't think we're at the same stage yet with respect to VTE as we are for AFib. I think the sort of traffic light scheme of the 2019 PE pulmonary embolism guidelines are actually quite useful, because they give some nice examples also of the green, the yellow, and the red situations with respect to the risk factors, and again some examples like minor surgery, for example, if you've had a thromboembolism after a minor surgery, it would give you an intermediate risk for recurrence, kind of in the order of 3 to 8% per year. Whereas if you're, for example, in a situation with an active cancer, then obviously you're at a high risk. And we'll talk about the cancer later on. And based on that, really, the guidelines recommend in which situations it is recommended to go with only 3 months of therapy after a thromboembolism, after a VTE, versus when to have an extended or possibly even a lifelong therapy recommended based on these factors. And I fully agree with you. I mean, the disease statistics of all of this is not excellent, not very good, but I think it is work in progress. And from a practical point of view, I think it's quite useful.
Absolutely, and I think it's worth reminding our audience that risk is not a static phenomenon. Risk is dynamic, and that applies to risk of venous thromboembolism, the risk of stroke in atrial fibrillation, the risk of bleeding in atrial fibrillation, and the same way as we have been talking about assessing risk in terms of venous thromboembolism recurrence. There's also a whole literature on trying to assess the potential for bleeding risk in patients getting anticoagulation, which completely misses the point, because risk scores for bleeding are there to draw attention to modifiable bleeding risk factors that can be mitigated. And furthermore, we as clinicians need to know who's the high bleeding risk patients that we can flag up for early review and follow-up. That's what bleeding risk scores should be, how they should be used responsibly and appropriately, and none of this focus on a simple static risk factor. And in fact, some bleeding risk scores are entirely or predominantly focus on non-modifiable bleeding risk factors. And age is a very powerful driver of thromboembolism, whether stroke or venous thromboembolism, but age is also a powerful driver of bleeding. So, you focus on non-modifiable bleeding risk factors, you miss the point.
Absolutely, and this is such an important and such a moving target. Also, I think we could easily discuss for half an hour on that alone, and I think we would not be boring. If on the other hand, it also tells us or shows us that we need to individualize our therapy based on which patient, with which risk, with which modifiable risk for reading, but also with which overall risk for be it stroke, be it thromboembolism is in front of us. And here in the VTE, on that aspect, on the VTE side, we have also seen a pretty big paradigm shift, in the sense that based on what you just told us earlier, we had 10, 15 years ago, we're in a completely different situation right now. But again, when we take a look at the trials, we do have some differences between the drugs. And this time also with respect to the trial designs, because there were some fundamental differences here compared to, for example, the stroke prevention trials with NOACs. The most, I should say the most that catches your eye immediately is that they're for the dabigatran and for edoxaban, the initial phase of therapy for a VTE, say I have a patient with a VTE, want to treat the patient with a NOAC, and the initial phase needs or was done with a heparin. And as a result of that, this is the way that these drugs are approved today. So you would have to give a lead-in with a couple of days of heparin, and then followed by the treatment dose of the NOAC, so the dabigatran or edoxaban. Whereas for rivaroxaban and for apixaban, a single drug approach was used. What that means is that in the initial phase, you'll go with the NOAC from beginning to end. But in the initial phase, you give a higher dose. In the case of rivaroxaban, it's 15 milligrams twice daily, whereas for apixaban, and that's actually for 21 days. Whereas for apixaban, it's 10 milligrams twice daily for a week, so for 7 days, which is then followed by the regular treatment dose. And this is important to keep in mind. And I think it's important to remind ourselves and also our audience about this, because we do see a lot of situations where this is not entirely done correctly in clinical practice. And I think the one recipe, I guess, that we have in order to improve outcomes is if you want to reproduce the trials, the good results from the trials, it's mostly a good idea to stick as closely as possible to the way that it was done in the trials. And there were some important differences. Now, maybe Greg, you want to briefly run through the top line results of those trials? What did we see with respect to efficacy and with respect to safety for NOACs versus standard of care for VTE treatment?
Well, absolutely, and I think the trials, as you say, there are differences how the trials were constructed, and then in the sense that reflects how the label is currently. It's worth bearing in mind in many healthcare systems, venous thromboembolism management is becoming an outpatient practice, and you know, certainly when I was junior doctor, which was in the dark ages, we admitted many patients with venous thromboembolism, and nowadays in our wards, you know, they're mostly managed as outpatients. But the trials, I think, they are very compelling. If you look at the meta-analysis of the randomized trials, when you look at the primary efficacy endpoint, you'll find that for the NOACs, they are largely non-inferior to standard of care, which generally, for standard of care, I'm referring to heparin and vitamin K antagonists. You start seeing differences when you come to safety, because you certainly see that for some of the NOACs, there is, for example, dabigatran and rivaroxaban, for the primary safety endpoints, they were at least non-inferior or not significantly different from the standard of care. When you came to look at the apixaban trial Amplify, or if you look at edoxaban in Hokusai VTE, there was actually a reduction in the primary safety endpoint in favor of those particular NOACs. If you look specifically on major bleeding in terms of the longer term, that is also reflected in some of the particular trials for apixaban and rivaroxaban, and in terms of major bleeding, particularly for the long term. But if you take the broader definition of bleeding, which is major or clinically relevant non-major bleeding, we certainly see less major or clinically relevant non-major bleeding. Otherwise, the composite bleeding outcome certainly better safety for apixaban, better safety for dabigatran, better safety for edoxaban. But do bear in mind what you know, the differences in the protocol, because as you say, with the dabigatran and edoxaban label and the trials, there was a heparin lead-in, whereas for apixaban and rivaroxaban, there was no necessity for that heparin lead-in at the start for the NOAC intervention. I think we should just move on, perhaps, to looking at cancer and VTE, because I think it's worth highlighting the studies there. And perhaps, Jan, you might want to kick off by some of the data we have. We can start with the historical data, of course, but specifically on venous thromboembolism patients related to cancer.
Yeah, absolutely. I think it's a very important topic, and indeed one where which is a little bit different from what we have been discussing so far, because the standard of care here was usually traditionally not vitamin K antagonists, but low molecular weight heparin, and this dates back all the way to the CLOT study, which back then compared dalteparin versus VKA, and indeed found a reduction in VTE, but actually even a potential mortality benefit. So this is why, as a result of this, really essentially, this has been considered the standard of care. And fortunately, we do have some data now also with the NOACs, particularly with edoxaban from the Hokusai VTE cancer trial. This was the first one that investigated this. And most recently, and this was published in April of 2020, if I recall correctly, then the Caravaggio trial, also with apixaban. And I think if you want to summarize these two, in fact, what it shows is that at least from an efficacy point of view, you are at least not worse, and there are even data that indicate that you're better with the NOAC, with edoxaban or apixaban, as compared to the standard of care, and this is in this case now dalteparin and not VKA. On the bleeding side, in the Hokusai VTE cancer trial, there was a signal for an increase in bleeding, which was confined, however, to gastrointestinal bleeding with edoxaban over dalteparin, and particularly gastrointestinal bleeding in patients with a gastrointestinal cancer. So this is, from a practical point of view, one of the situations where I would not recommend to use edoxaban if you have a patient with a cancer that has a VTE and that needs to be treated. Now, this signal was not seen in the Caravaggio trial. There was no difference in major bleeding, which is obviously a very positive finding, and not even for gastrointestinal bleeding. Now, of course, a cross comparison to AFib is always a problem because it's two different entities and completely different situations. But it is surprising, or probably not a coincidence, that also with the apixaban, there is no increase in GI bleeding as compared to VKA in AFib. So the gastrointestinal safety for apixaban, I think, has been shown across various trials in various situations. Now, with that being said, given the data from the HOX-IVT cancer trial with edoxaban, and given the logical rationale that if you have a gastrointestinal cancer, an active GI cancer, and you have a drug that is active in the gut, I still shy away. I'm looking forward to hear your thought on this, Greg, but I still shy away a bit of using NOACs in general, even apixaban for that matter, or for VTE treatment in these very specific patients. Now, for the remainder of cancer patients, I think it is a very good option, and we certainly have very good data as the ones that I was just briefly discussing. What do you think?
Wow, I always agree with you, Jan, as you know. So in that sense, those are very practical tips, which hopefully would be of great use to our audience. Well, I think we are really just about out of time. And I think by way of summary, I better offer a few SMART goals, which are the specific, measurable, attainable, relevant, and timely action items as take-home messages. And firstly, consider randomized clinical trial data and real-world evidence with the DOACs when individualization of therapy of patients requiring anticoagulation, including the elderly and fragile patients, the patients with obesity, those with cancer, or where you have multimorbidity or polypharmacy. It's worth re-emphasizing implementation of guidelines and best practices to balance anticoagulation. Consider venous thromboembolism prophylaxis with DOACs, and including long-term treatment where appropriate, especially for patients with cancer and associated multimorbidity. Well, I would like to thank you, Jan, for a really insightful discussion today. Thank you, our audience, for joining us. So please stay safe, everyone. Thank you again for participating today.
Take care. Bye-bye.